This is a presentation on chronic inflammatory demyelinating polyneuropathy, or CIDP. This was initially an assignment for my master's program, but I wanted to share it to spread awareness of CIDP and hopefully provide some education as well. My resources are provided at the end of the presentation and are each within the last 5 years and peer-reviewed. In this presentation, we'll review CIDP, including what it is, its diagnostic criteria, subjective and objective findings, most effective pharmacotherapy, nursing considerations, expected treatment outcomes, and what an appropriate holistic treatment plan may look like as part of follow-up care for someone with CIDP. Chronic inflammatory demyelinating polyneuropathy, or CIDP, is a chronic neurological disease in which the immune system attacks the peripheral nerves, damaging neuronal axons. What this means is that our own immune system starts attacking the cells that send signals back and forth. These cells help us detect senses like touch or temperature, and they also help us with motor control. This disease is basically blocking the neurons from sending signals to the brain and receiving signals from the brain along the central nervous system and peripheral nervous system. It can be debilitating and often precedes comorbidities, which reduce quality of life. Its exact etiology is unknown, though recent evidence has found that those with CIDP often have a high frequency of perforin gene variations. Perforin gene variations which alter the functions of cytotoxic T cells and natural killer cells, key contributors to the immune response. Its onset can be at any age, and it usually develops over a period of 2 or more months, unlike acute neurological diseases. CIDP can present in several variants, such as typical CIDP, pure motor, pure sensory, multifocal or Lewis-Sumner syndrome, and relapsing remitting. There are limited resources and publications which provide a comprehensive overview regarding CIDP, its burden, modern treatment options, and economic costs, indicating a need for further focus and research. Here's a simple table describing the main types of CIDP, which are classified into typical and atypical cases. At least 15 diagnostic criteria and numerous manifestations characterize CIDP and its variants, leading to frequent misdiagnoses and ineffective treatments. These are examples of the characteristics which define CIDP variants. The presentation will focus on typical CIDP, which is characterized by distal neuronal demyelination in the hands and feet, and depending on the case, may radiate more proximally or towards the center of the body. Typical CIDP makes up 50 to 60% of cases. Pure motor is characterized by symmetric muscle weakness, loss of deep tendon reflexes, or areflexia, and spares the sensory nerves, whereas pure sensory is the opposite. Pure sensory CIDP affects only the sensory nerves symmetrically, sparing motor nerves. Multifocal, or Lewis-Sumner syndrome, is characterized by conduction block in the nerves, as shown on nerve conduction studies. This type is characterized by both motor and sensory loss and is asymmetrical, unlike typical CIDP. Relapsing remitting is a pattern of CIDP but is not seen in all types. Subjective findings of CIDP include paresthesias, such as numbness, tingling, burning, or pins and needle sensations. Some experience shooting nerve pain. Early signs of neuropathies and paresthesias are not always subjective and can be assessed objectively using diagnostic tools, such as the nerve conduction studies I mentioned. Many patients report generalized fatigue and low energy. Some individuals report having to take frequent rest breaks between activities and avoid high temperatures, as these may trigger exacerbations, similar to what we see in multiple sclerosis. These findings develop over 2 or more months and can help in differentiating from acute syndromes such as Guillain-Barré syndrome. Objective findings of CIDP are measurable and determined through imaging, laboratory testing, and physical examination. MRIs with T2 flare or stir sequences post-contrast can show nerve and tissue abnormalities. Imaging may show enlargement of nerve roots and peripheral nerves, as well as paraventricular brain lesions that resemble the enhancing lesions we see on MRIs in multiple sclerosis. Figure 1 shows paraventricular enhancing lesions in a patient with CIDP, appearing as hyperdensities within the tissue after contrast administration. This MRI could be mistaken for someone with multiple sclerosis if further tests and assessments were not completed to allow for a differential diagnosis. You can clearly observe some paraventricular lesions here, as well as a few juxtacortical lesions which are farther away from the ventricle, but not directly contacting the cortex. Other objective findings include tremors, muscle weakness, areflexia, impaired coordination, elevated spinal fluid protein, and fatigue. Fatigue can be measured using tests such as the Time 25-foot walk test, which also measures gait speed and mobility impairment. It is repeatable and helps physicians assess subtle declines or improvements over time. There are a lot of ways to help us make the diagnosis of CIDP. Physical examination is vital and includes assessment scales, such as the INCAT and IRODS, or the Inflammatory Neuropathy Cause and Treatment Scale, the INCAT, and the Inflammatory Rash-Built Overall Disability Scale, or the IRODS, which help evaluate mobility impairment, fatigue, and both subjective and objective symptoms related to disability affected by neuroinflammation. Laboratory tests can be performed to support a diagnosis of atypical variants by searching for those perforin gene variants, elevated spinal fluid protein levels, and testing for antibodies such as the contacted 1 or neurofascin 186, which are frequently found in some CIDP variants. Electrophysiology is fundamental for a CIDP diagnosis. Nerve conduction studies can show evidence of demyelination. As discussed previously, MRIs and ultrasounds are imaging studies that are key to diagnosing CIDP as they provide objective findings which can be studied over time. Diagnosis of CIDP is multifaceted because it's easy to misdiagnose. To ensure these patients receive the optimal treatment for their disease, physicians should be specific in their testing and assessments. There is no cure for CIDP, though there are pharmacotherapeutic options to help relieve patients of its debilitating burden. The majority of these therapies are immune modulating, either helping or suppressing the immune system to reduce the inflammatory response. The main goal of therapy is to maintain long-term remission in which patients have minimal to no disease symptoms. One first-line therapy considered is corticosteroids. They are initially administered at high doses daily for rapid response, then tapered to maintain remission. Long-term adverse events are often seen with corticosteroids, however, causing weight gain and Cushingoid symptoms. Another first-line therapy, which is prescribed in most CIDP variants, is IVIG, an intravenous infusion of immunoglobulins derived from over 5,000 plasma donations, aimed at strengthening the immune system by allowing healthy antibodies to neutralize harmful autoantibodies and reducing inflammation in the central nervous system and peripheral nervous system. In turn, IVIG helps protect myelin from further damage, slowing down disease progression. Plasmapheresis exchanges plasma. Components of plasma, such as cytokines and antibodies, may contribute to the disease and can be replaced through plasmapheresis. This is often done when patients do not respond to first-line treatments or when exacerbations of CIDP occur. Each therapy differs in its cost, availability, and adverse effects. One adverse effect of plasmapheresis is its hypotensive effect, so this should be considered when deciding this for therapy for patients. Third-line pharmacotherapy includes monoclonal antibodies such as rituximab, its brand name Rituxan, which suppresses the immune system. Mycophenolate mofetil, or Cellcept, is sometimes used off-label for CIDP to help mitigate autoimmune attacks on neurons. These third-line medications are often used in combination with corticosteroids. Now, plasmapheresis is a second-line therapy, however, it's also considered complementary. Symptom control is often used in tandem with other therapies. This can include physical and occupational therapies, neuromuscular electrical stimulation, assistive devices, and acupuncture. Many medications are still being investigated for their potential to influence the immune response in CIDP. In this diagnosis, it's important to remember the main issue patients have: peripheral neuropathy. You may have learned that with type 2 diabetics, peripheral neuropathy can lead to serious complications like toe amputation, for example. If CIDP is not diagnosed quickly, lack of urgent treatment may lead to more severe complications. Peripheral neuropathy can increase the risk of impaired skin integrity or perfusion, leading to ischemia, and in severe cases, amputation. It can lead to disturbed sensory perception, impaired mobility, and chronic pain. Nursing care we can implement includes inspecting the skin for abnormalities such as pallor, altered sensation, changes in skin temperature, and capillary refill exceeding 3 seconds. Encouraging movement of the affected extremities and educating the patient on proper use of assisted devices is also important in preventing complications. Even reminding the patient how to use their cane or walker can strengthen their practice, and, as small as it may seem in the moment, it could help prevent deadly falls in the future. Repositioning, especially if the patient is immobile, is very important. I can't stress this enough. The standard timing for repositioning is every 2 hours, but I encourage you to do it whenever you check on your immobile patient. Give them a little shimmy every hour or adjust their arms and legs while you're in there. I linked a nursing focus article by Megan Baker, BSN RN CCM, in the description if you'd like to learn more about nursing considerations for peripheral neuropathy, and I think it's very helpful. She did a great job writing it. There is no known way to prevent CIDP, as it is an autoimmune disease with no known cause. Treatment outcomes aim to include improved quality of life, symptom management within 1 to 3 months, and minimal to no symptoms, disease remission. There are many expected complications of CIDP. Aside from treatment-related complications, sensory loss and motor loss are common. These complications can lead to falls, injuries, and progressive weakness, like we talked about. Misdiagnosis can lead to incorrect treatment and cause the disease to go untreated. Autonomic dysfunction, such as bowel or bladder dysfunction, can also occur. Treatment and disease management can be costly and have a psychosocial burden on patients as well. These expected complications can also vary across the lifespan. As someone ages, they are less likely to reach remission and heal from demyelination. Normal aging causes the adaptive immune system to become less responsive to new antigens. This population is also more likely to have severe complications and suffer from them. For example, falls from motor and sensory impairment can lead to long hospitalizations for older adults. The overall treatment plan varies case by case. Those with a suspected diagnosis and experiencing hallmark symmetrical paresthesia should be referred to a specialist as soon as possible. If an autoimmune exacerbation is identified, determine whether emergency corticosteroid intervention is necessary. After treatment initiation, the patient should follow up in 1 to 3 months as advised by the physician. In those with an established diagnosis, it's common to see a specialist annually. They may see varying specialists depending on their needs, such as a neurologist, neuroimmunologist, and physical and occupational therapists. It's important for these patients to follow up with their care team because CIDP is chronic and progressive. It should be monitored over time to measure progression and document changes. Since CIDP has the potential to be a highly debilitating disease, resources should be offered to support these diagnosed individuals. In summary, it's important to remember that further investigation into CIDP and its treatment is warranted, as its etiology remains unknown. Symptoms vary from case to case. However, most people with typical CIDP experience symmetrical paresthesias in the distal parts of the body. Diagnosing CIDP is multifaceted because misdiagnosis is common. There are limited treatment options for CIDP, but their efficacy is high. Corticosteroids and IVIG are the most common forms of treatment. Nursing considerations may focus heavily on interventions for peripheral neuropathy to help prevent skin impairment and injury. Expected outcomes include improved quality of life through symptom management, yet there are many expected complications with this disease as well, including risks of complications that increase with age. Follow-up care includes seeing a specialist at least annually to ensure the optimal management of this disease. Thank you, and I hope this quick presentation helped you better understand CIDP. Please let me know in the comments if there's another topic that you would like covered, or if you have anything to add to this discussion on CIDP. I would be open to learning about your experience with this disease.